Thank you. I'm going to talk about something else. There's some young people here. Going to hear talks about all different things. But there's something that, I feel I've been exposed to over the last day that is unique. It's called people. And this makes the whole difference. I've come to know a bit better Raphael. I know Yehuda from his time in Israel. I've heard the talk of Mike Edwards talking from his heart. Our profession is about people, and the families that sit in front of us are looking for someone to hear. My mentor, Howie, sitting behind, has been such a mentor to me, has been a mensch. And I think you're lucky because you have this atmosphere here with Raphael, with Yehuda, and the rest of you, that I think that makes a difference. So we can talk about presentations and titles and all that, and it's important, but there's something more important that is not in any textbook, and it's much more important than how to be a carpenter. You'll all be great carpenters. You'll all do a very nice incision and close the skin and do a perfect hemispherotomy and have statistics and tables and publications. But that's not the most important thing. So I must say, Yehuda, Raphael, thank you for putting up this very special event. Thank you personally for inviting me, for inviting my wife. But really, this is an opportunity for the young people behind to really look beyond the technical aspects of what we're talking. Okay, I've mixed your mind too much, so I have to give a talk. And the fun thing about academic neurosurgery is to look how to poke a finger in someone's eyes. Do you know why you do fellowships? Because you go for a fellowship to see that everything you've been taught about can be done differently, the exact opposite than what your actual boss told you, and that it's okay. And that you see people in other places around the world do exactly the opposite, and things survive, and the patients survive, and sometimes they even do better. So academic neurosurgery is part of it. And you ask yourself, when you see a certain case, is it true what you've been taught? So let's talk about early surgery for epilepsy. And the questions I have is, should we wait for refractoriness in order to go for surgery? How much should we be conservative? Should we go for endless drugs? And you know the statistics that once your patient does not respond to the second, third drug, the statistics are that he will most probably not respond to drug N+1, doesn't matter what it is, or put the VNS. Well, we talked about that before. Does the duration of epilepsy affect surgical outcome? And is there a lower age limited for surgery? So I'll try and give you a few answers. So you've seen this endless times today, but just once again, you see that epilepsy surgery is not a miracle. It helps, but it doesn't stop the whole thing. We talked about the shortcomings of this graph, that this is an angle 1. Well, angle 2 is very good also. You don't have to say that. I mean, it's an absolutely of value also in the quality of life and behavioral scores, etc. New onset temporal lobe epilepsy in children usually will be related to some kind of lesion. Well, new onset, first seizure. Should we now go for surgery or should we follow? And usually it will be a low-grade tumor, so it's okay. Oncologically, it's probably okay to follow. But if you look at these patients over the time, then most of them, all the lesional ones, MTS, dysplasia, tumors, will develop chronic and refractory epilepsy. Well, this is most probably what's going to happen. So should we start by giving them drug number 1, drug number 2, or drug number 10? What is the effect of epilepsy duration on the actual outcome, on the seizure outcome? Well, one series, actually from Israel, looking at nearly 50 cases, children with epilepsy related to temporal tumors, showed that the outcome did not correlate with the duration of epilepsy. Another series of nearly 40 cases, children and adults, temporal lobe, mostly glioneural tumors, showed that 80% had an LGN1 unrelated to the duration and the chronicity of the epilepsy. Well, they all had chronic epilepsy. In a study that we did about extratemporal epilepsy, we showed that when you take these patients who had more seizures in their history, their outcomes, meaning their actual rate of recent seizures at the last follow-up and the actual number of antiepileptics was inversely related to the number of seizures they had before surgery. So if you want a better outcome, don't wait till the patient will have 10 seizures, take him after 1 seizure to whatever you think should be done. Again, going to temporal lobe, this is another series, this time showing that the 5-year cutoff of duration of epilepsy did change the outcomes of the seizure control over time. In another one, seizure for less or more than 1 year made the difference. So once again, it seems that there is value of early surgery. Another series, time is brain, you've heard that statement before today. Again, temporal lobe epilepsy. So the epilepsy duration at about trade-off for 10 years showed the difference in the outcome in the seizure control. Many of the cases were children, not all. Obviously, you see a very large adult number. So what is the impact of the epilepsy duration and the neurocognitive outcome following surgery? So this is, once again, in children, glioneural tumors, big series, and they showed that the pre-op full-scale IQ correlated to the epilepsy duration, and that post-op IQ correlated to the pre-op IQ. So I would deduce that the post-op IQ is related to the seizure duration, to the epilepsy duration. Another one, not specifically about the temporal lobe, but for focal epilepsy in children, showed once again that epilepsy duration was inversely correlated with pre-op IQ, meaning the longer the duration of the epilepsy was, the worse IQ was before surgery. And like we saw before, it impacts the post-op outcome. Another series also combined children and adults looking at temporal lobe epilepsy, showed once again that cognitive outcome correlates to pre-op neurocognitive status. So once again, eventually related to the duration of epilepsy. And another series talking about temporal lobe epilepsy in children talks about significant improvement in full-scale IQ over a few years since surgery. Once again, shows that it's worthwhile to go for it. So don't be afraid, even in left-sided temporal lobe epilepsy, it's worth to push the limits and go for surgery. These children will improve. And another series talking about a 6-month cutoff. So I think the idea is not the exact number, but the general theme that early epilepsy leads to better post-op neuropsych outcomes. Again, temporal lobe showing that elder age at onset and shorter duration of epilepsy had better post-op IQs than compared to their control groups. Okay. So often, especially in temporal lobes in children, we talk about them being secondary to glial neurotumors. So are they really so benign like we tend to say? Because if they are benign, okay, so even oncologically we can follow. However, if they're not so benign, it's a different story. Then even from the oncological point of view, you want to push for early treatment. So we see that progression-free survival is related to the extent of surgery. But what does this mean? It means that these tumors don't stay stable. They do grow, because if you take and you leave a piece and that piece grows, then obviously then it's an active tumor. And there, if you look in the internet about malignant transformation of DNET or gangliogliomas grade 1, you're going to see a plethora of case reports talking about malignant transformation. So it is rare, yes, but it still can happen. And obviously we have no clue who's going to transform over the time. So what is easy to say? When is there a wide agreement? When we're talking about a non-dominant side lesion with an active epilepsy and refractory disease, or for a progressing lesion. So surgery has the best chance for seizure control, for reduction of meds, improvement of quality of life, and neuropsych outcome, and tumor control, of course. When will we have a dispute? Well, for dominant-sided epilepsy, obviously more related to language regions. For kids with stable seizures on a single anti-epileptic drug, for intact cases where they have the more potential to be injured, and for stable lesions. However, there's a high chance for epilepsy recurrence, like I showed in the first slide, that even stable epilepsy on the long run will probably develop into refractory epilepsy. A small chance for malignant transformation, and surgery still has the best chance for cure and reducing antiepileptics. There are surgical risks, however, some of them, well, I would downregulate them, not totally, but still take them in with proportion, especially visual field issues. Visual field, I don't ignore them, but I think should be taken in the correct context, especially if someone has refractory epilepsy. And neurocognitive risk, yes, there is. I rushed that slide because I don't think this is, we don't need to go into too much of the depth, but there are some papers who do discuss some injury in the neuropsych outcome. Obviously, they're more relevant in the dominant side, and we do need to take them into account, but probably with a lesser weight. And there is a valid alternative for these cases. When they are stable on drugs and their lesion is stable on imaging, you can follow them. However, once again, there are two sides of the discussion, and you need to extensively discuss these things with the family. And remember the basic statement that music does the thing. Music has a major importance. If you're going to talk to them about the fact their child has a brain tumor and he has to go to surgery, it's one thing. But if you take things with I would say with the same way you would have wanted someone else to talk to you. First of all, there's no rush. There's no urgency. You can follow these cases. It's absolutely legit. And you know they're going to have a recurrent of their seizure, but it takes time for a family to build up their confidence and to come to this decision. It's not a 1 and 0. It's a longitudinal thing. And many cases, I ask to see these families at an earlier stage because I think they should be partners from an earlier stage and not come to the neurosurgeon as a last thing before yes, no surgery. Because I want to be part of the team that will be following them, even if I'm not taking them now for surgery, because I want to build up a relationship with these families. So like I said, I enjoy poking people in their eyes. And I had 2 cases during my career of very early refractory epilepsy. One case was about 1 month, the other one was about 2 months. And obviously they failed whatever was relevant. These cases get tons of medication and sometimes they're ventilated on all different drips. And I debated if to take them for surgery. One was a lesionectomy, the other one was a hemispherotomy. And one of my teachers, a very esteemed person, told me, wait, they're too small. Don't remember what the weight was, about 5 kilos, 6 kilos, whatever. They're too small for surgery. Don't take them now for hemispherotomy. It's a huge surgery. So I did what I think any neurosurgeon would do. I waited till that guy will go abroad and I took him for surgery. No, I'm joking. He did go abroad, and the kid did go for surgery, but nothing was done behind anyone's back. But obviously the outcome was good. And I felt that this axiom not to take someone to surgery because they're too small, etc., is a bit arbitrary. And I asked people around, and I got various answers. So then we decided to do this study, and to recruit people to participate in such a study is not a trivial thing. I approached many friends and friends of friends, etc., and asked people, do you have any cases? And many very experienced surgeons, much more experienced than I was at that point, told me they had no cases. But I did start to get from here and there some numbers. And then we built up this series that was a beginning of additional collaborations in epilepsy. And I'll show you the results. So this part, Howie helped me a lot also with this part of the presentation. Thank you, Howie. Well, this is the greatest challenge in pediatric epilepsy surgery. A newborn child, let's say a few weeks old, with this MRI has endless seizures, uncontrollable, and what do? So I would say the motivation for surgery as a surgeon is not high. This is a very highly morbid, especially blood loss, etc. case. So is it safe or not to do the surgery? What's the actual safety profile and what's the epilepsy outcome in such cases? And obviously, not taking for surgery has a bad impact on the neurodevelopment. So we did this retrospective study. I approached 35 centers worldwide. 19 centers contributed from all around the world. 1 to 10 cases, and you see that out of 19 centers, only 3 had beyond 5 cases to contribute to the series, which means that people have very small numbers in this specific topic. And we had altogether 64 patients undergo nearly 70 surgeries before the age of 3 months. The vast majority had very active seizure disease. Many of them were having status epilepticus. 2/3 were on IV barbiturates or benzodiazepines, and a third were intubated before surgery because of their epilepsy. Although the young age, They had a median of 4 anti-epileptic drugs, meaning some had many drugs or failed many drugs. The earliest surgery was 2 weeks old, the maximum 3 months. About 70% had hemispheric disconnection slash resection. 20% were anatomic resections. So the vast majority were big surgeries. There were all different other smaller surgeries, like you see. The etiology of the pathology is down there. You see a lot have cortical dysplasia, hemimegals, etc. All patients got blood. Some got a lot of blood. Well, the average was about 1 blood pack per patient. Many of them got other blood products, like you see. There was some intraoperative complications, sorry. You see hypotension, hypothermia, and respiratory. You see here the rates. There was one aborted case of a hemispherotomy due to DIC during surgery. There were no perioperative deaths and no major unexpected permanent morbidities. Obviously, whoever underwent hemispherotomy had relevant post-op neurological findings, but there were no unexpected neurological deficits. And there was a high rate of hydrocephalus for those who underwent hemispherotomies. About a third needed additional surgery of resective surgery. 2 were planned. Overall, 2/3 had a very good epilepsy outcome. About 80% took less drugs at the last follow-up, a median of 2 drugs. And about a fifth were on no drugs at all. We saw that comparing hemispheric surgery versus focal resections of all kinds, there was no significant difference in any of the outcomes. So what is my take-home message from this specific series? Epilepsy surgery is before 3 months of age is very rarely done. Most of surgeries are big surgeries, hemispheric surgeries. The epilepsy outcome is excellent, and it leads to a reduction in the drugs. However, and this is an important thing to say, eventually life is not what you read in any textbook or any paper. Life is a combination of many small factors. You have to do the job on the surgical side in the most really high-end way to prepare, to do it with all the small details taken into account, anesthesia, the best, ICU care, the neurologist, everyone really has to be recruited for this mission. These results it's very dangerous to extrapolate this just as a title. This is a very selected group done in very high-end centers all around the world. And I'm sure that just taking this thing as a title is dangerous. So beware of this. So how do I sum up my presentation? Epilepsy is cancer, you know what I said before, and we can help these kids. Age is not a cutoff for this thing. However, there are many small details, and this collaboration, and I think this morning I heard the neuroradiology talk. When I sit in my epilepsy meetings, I think the radiologists have a lot of confabulations because they see things that don't exist. However, what this talk this morning that was really good proved to me that it's all about the group. Because if you have an excellent neuroradiologist and you have an excellent neurologist and you have a good surgeon and you have this team, then everyone contributes. And there's a discussion like every one of you know because you're all part of these things. And that makes a difference. So it's a matter back again to the people. It's all about the people. And when I talk to the radiologist until she tells me, listen, I think I see there's something and I have no clue, I look again, and often I will see that she may be right. There's something very subtle. But then the neurologist will say, listen, but the EEG is totally from the other side. So then the radiologist will see the same thing on the other side. And this is a discussion, and you build up a hypothesis for the SEEG, etc. It's an ongoing process. It's complex. There's no simple epilepsy surgery. Simple epilepsy surgery probably is in other hospitals, exactly like prior speaker said. We see more and more complex cases. However, I think like the last talk, that I love the idea that you convert the non-lesional talk to a lesional talk. I think this is really where things are going. You have all the DBS, etc. But all these subtle things, these make the difference. And here, the radiologist and the neurologist, these are all the small contribution. Age is not part of this thing. As long as the kid is healthy, obviously you will not take someone who's moribund, but that's not the case. Thank you. questions? I should be selling things. Look what a great audience. Everyone's convinced.
Thank you very much, Jonathan.
One second, another question. Yeah. Georgia? Yeah.
Thank you. I can talk loud. It's okay.
No, there are people maybe online.
Yes, of course. So, thank you very much for an excellent talk. It's really inspiring. And why should we wait for something that can be done now? I have a very practical question. You just showed the rates of hydrocephalus, which were 25%, and the international rate on the procedure is about 15%. So the rate is quite high. And how do you explain it? And the other related question is the the discussion between vertical and horizontal hemispherotomy. And most of the cases that you showed are actually hemibicalencephalus. And there are many people who would be very reluctant to proceed to hemispherotomy laterally, and they would prefer the vertical approach. And if this could be a contributing factor to the high rate of hydrocephalus in the study.
First of all, I don't know. The rate of hydrocephalus in elder children after hemispherotomy is low. My personal rate is about 3-4%. I totally agree. Obviously, I can give you the theoretical explanations, a very small kid, ventricular involvement, debris, all these factors. I guess it's some combination of all these things. This is from many centers, so it's a mishmash of data. I don't know. That's the answer. But if you ask me if 25% hydrocephalus, if that should change the decision, absolutely not. We have options to treat hydrocephalus. This is a kid that is dying, or his brain is dying in front of our eyes. His developmental condition we're losing neurons. And I really think, obviously, you don't take the simple controlled cases. You take the more complex ones. You saw intubated on all the drugs, etc. So I think the idea of this series and this concept is to tell you as a neurologist, neurosurgeon, whoever, don't wait just because he's 2 months. If that is a compatible to significant to catastrophic epilepsy, go for it. You can help him. Yes, he may need a shunt. So what?
Any further questions?
Howie?
Yeah, so I love your discussion on the asymptomatic stable tumor. That's such an interesting area. I agree. In theory, everybody should have a release surgery, but it's so individualized and depends on so many factors. I find that the key thing is that they meet like you said, they meet the surgeon right at the beginning, because sometimes they come in a few years after diagnosis. Oh, if we would have known, and the other thing is the anxiety of living with this lesion. They don't know when the next shoe will drop, when the next seizure will happen, when they'll end up in the emergency room. It can happen at any time. So it's like a ticking, even though things are quote unquote stable. But if it's in the dominant mesial left temporal lobe, there are issues in a child that's high functioning. So I think it needs to be, there's a lot of art to this too.
Maybe one last comment.
You're doing it on purpose.
No. Some exercise never hurt anyone.
Howie, prepare for another question.
It's actually a comment. I just wanted to say, since this is a neurosurgical meeting, that there is this interesting study from Massimo Cosciu from Italy, who actually compared patients who were patients with tumors that underwent epilepsy surgery. So a big study group, around 100. Some of them were already pharmacoresistant and some were not. And those who were not pharmacoresistant had much higher rates of seizure freedom after surgery. And the difference was at least 10%, something like 15%. So I would say that even this publication from Italy should suffice to say that we could offer surgery for epilepsy. And this is actually also what the guideline from the ILA is based on. It has already been done.
I underline you are a neurologist.
I'm a neurologist.
And she said that.
She's a neuropediatrician.
Neuropediatrician, yes.
Whoa.
Neurologist for the very young. I'm specializing in very young children.
No, I think I want to underline her point and also come back to the article or the series Howard Weiner showed in the tuberculosis with these frequent subclinical seizures. And, the fact that it's subclinical doesn't mean it doesn't do anything, not even during the seizure or right afterwards, but all the time. Because when we see a seizure, it's the tip of the iceberg. So there's a network of epileptogenic network. There's plenty of evidence in fMRI and other studies, EEG only. There's a network installed, and even if you take away the component of the spikes, the discharges themselves, the network is there and it's pathologic. And I think every surgery or team should aim at interfere before the network is established. I think that's the next challenge, to convince everybody to not wait for pharmacoresistance, but go there.
Do you think this crowd represents the real world of neurologists?
No.
Not surgeons?
No.
Yeah.
Well, we are at the beginning, no?
Yeah, we're at the beginning for many years, but yeah.
I think for many years it was the verdict of 2 anti-epileptic drugs. And in reality, at least in adults, it was then 3, 4, or 5. And then, somebody came along, oh, it's a new drug, try that, and done. And the year passed. So I think that was quite, theorem or so, to have the 2 drugs for legal issues. If something went wrong, you wouldn't be good to
but
just
even
try
for
one.
2 drugs, refractory 2 drugs, children, do you see these cases early? The neurologists in the community, will they refer them for pre-op evaluation, for surgical evaluation, or it will take them another year or 2 to come to to understand that that they need something else?
Well, I can speak only for adult patients, and they're slightly different stories. So some of them enter a several years remission, so you don't know. Then we have patients who have amnestic seizures. So the dogma, if it's in the right hemisphere, then we operate and we don't touch the left one. It should be the other way around, because the amnestic seizures, they come from the left hemisphere, and they are very difficult to follow. Patient sits in front of you, says everything is fine, and from the pre-surgical evaluation, they don't remember their seizure. So that's useless, this statement. And then for the children, for the child doctors, pediatrician, I think you guys are much more dynamic than the adult neurologists. So, which is why we created a center for the first seizure. So we see patients and try to keep them in the center when you see this is focal and it's not going the right direction, because it's more difficult to follow in the periphery.